Aloha and welcome to week 2 of cardiovascular health. This week we'll cover electrocardiography. So with regards to objectives, you need to be able to identify what's called normal sinus rhythm, NSR, basic normal ECG waveform morphology, distinguish between ECG arrhythmias versus any artifact, determine the rate, which is heart rate, the rhythm axis deviation. So just as a review, the horizontal grid basically represents the passage of time. The vertical grid represents the speed of the electrical current traveling within the heart. So the distance in time between two heavy vertical lines that you see here is 0.20 of a second, but each light line is 0.04 of a second. So this is a summary of, if we consider the heart to be here in the center, the different leads that you have on a 12-lead ECG and the direction and the aspect that it's looking at the heart. So as an overview, 12-lead ECG provides views of the electroactivity of the heart in 3 directions: right to left, superior to inferior, and anterior to posterior. So with regards to the ECG leads, there's different leads. So there's what's called bipolar leads, and that's on 2 different points of the body. There's also unipolar leads, and that's where one point in the body and a virtual reference point, and it's located in the center of the heart. So if we look at the standard ECG with 12 leads, so there's 3 standard limb leads: lead 1, lead 2, lead 3. There's 3 what's called augmented leads: AVR, AVL, and AVF, and 6 precordial or chest leads, V1 to V6. So the axis of a particular lead represents the point or the way it looks at the heart. Just remember, it only takes 10 electrodes for a 12-lead ECG. So these are the limb leads. All right, so these are the bipolar leads. So they're leads 1, lead 2, and lead 3. And you can see it has 2 dedicated electrodes. So these are the extremity unipolar leads: AVR, AVL, AVF. So where A is augmented, V stands for voltage, and RLF stands for either right arm, or left leg. And if we look at the aspects of the heart they look at, you can see that there. Now, this is all the leads combined that we've covered so far, excluding the chest leads. So speaking of the chest leads, so that's V1 to V6. And you can see here midclavicular for right arm, V1, V2. You can see 4th intercostal space, see that over here. Then you can see V3, 4, 5, and 6. In lab, we'll teach you how to do this 12-lead electrode placement. Okay, so this is a 12-lead ECG. So one point that's important is, and you'll learn about this in the lab, especially for practicum placement, is the X-scribe systems that we have. You cannot use just the 3-lead ECG. 3-lead is right arm, right leg, left leg, etc. So you have to put a V5 on for it to work. So one question you can ask your tutor is, when or why would you use this configuration? So overview. So remember, you've got bipolar leads. They're in a frontal plane: lead 1, lead 2, lead 3. You've got the augmented unipolar leads: AVR, AVL, AVF. And then you have the 6 chest leads: V1 to V6. Now, when we look at doing EKG or ECG analysis, there's a systematic method that you want to use. Personally, I don't care which one you use, just need to make sure you go through all of these. So we'll go through it now in the basics, where we go through the rate, the rhythm. You'll check the P wave, and when I say the P wave, you'll look that there's a P wave present, because there's a number of arrhythmias related to if there isn't one. You'll check that for every P wave there's a QRS, and for every QRS there's a P wave, etc. You'll look at the PR interval, you'll check the QRS complex, you'll look at any ST segment changes, the T wave, any other issues that you might notice, okay? And then you'll look at the axis deviation. Is there a U wave present or a significant Q? And the QT duration. So let's look at heart rate. So generally you can look up on the ECG device and you can get heart rate from it. However, if you're given a hard copy and the heart rate's not on it, you need to be able to determine heart rate. So I'll show you a couple different ways to do that. So just as a review, when we look at what's called normal sinus rhythm, the pacemaker of the heart in normal sinus rhythm is the SA node, and it's located in the wall of the right atrium. So it has what's called automaticity, and if there's no other neurohumoral factors affecting it, you know, coffee, stress, etc., smoking, it usually fires at a rate of about 100 to 115 beats per minute. As you get older, that firing rate decreases with age. Now, heart rate is decreased below that intrinsic rate by the vagus nerve, because that innervates the SA node. And for example, you can actually do massages in emergency. They'll do that if somebody's tachycardic, and just rubbing bilaterally, but rubbing the vagal nerve, and that can slow the heart rate down. So at rest in normal healthy individuals, there is significant vagal tone on the SA node, so it actually decreases the heart rate down to about 60 or 80 beats per minute. Now some of you may be especially fit and have heart rate in the 50s, for example, or even 40s, high 40s. That's just increased vagal tone, which is a good thing. But you have to remember, at rest there's both vagal influence and sympathetic influences over that intrinsic rate. So what happens with exercise with heart rate? You know this from your undergraduate days, where basically you get vagal withdrawal, you get sympathetic activation, we see an increase in heart rate, then you stop heart rate, you're at peak exercise, go into recovery, we see that there's vagal recovery, meaning the vagus nerve starts to come in again, but we also get sympathetic withdrawal, and we see the heart rate returns back down to near its resting value. So here's a case study. So a Gold Coast MSEP student was testing a patient, a female, 59, she was osteoporotic. From musculoskeletal health, you'll learn this. She had a T-score of the hip of -2.7, and she suffered from vertigo, so she could only do a submax stress test on a cycloergometer. She's fit, she runs maybe 5Ks 3 to 4 days a week. Her exercise heart rate, normal sinus rhythm, goes up to 186 beats per minute. However, it should only be 161 beats per minute when you do the 220 minus age. So speak about this with your tutor, but what it means is as she's exercising in here with sympathetic dominance, it's actually, if you're an endurance athlete, it's hugely advantageous as long as you're in normal sinus rhythm, okay? Because remember, if you're an aerobic athlete, marathon runner, whatever, your cardiac output is heart rate times stroke volume. Well, stroke volume can only get so big, so much, so that if you can get your heart rate above, like here, it's going 25 beats above higher, she's got a massive cardiac output compared to others in her age and gender. So for heart rate to increase above the intrinsic rate, remember, simultaneously, you've got to withdraw vagal influence, and we have to increase or activate sympathetic nerves, and that increases it. The reciprocal change in an increase in sympathetic activity and a decrease in parasympathetic activity is why the heart rate can increase during exercise. Now, how do we take heart rate? Okay, so you can palpate heart rate. So typically we do it at the wrist, you can do it at the elbow, you can do it at the neck, etc. One, if you can't get a pulse at the wrist or you can't get it at the elbow, the brachial artery, then, you know, if you do go to the neck, you have to be careful that you don't press too hard so you don't occlude blood flow. When you palpate heart rate, you always have to report rhythm. So it's either regular, irregular, or irregularly irregular. On the ECG, you'll always report the rate. As I mentioned, most of them show up there. The rhythm, is it normal? Do they have any ECG arrhythmias, axis deviation, and E intervals? Now, determining heart rate. So in the old school ways, there used to be these calipers. You'd use those. There's the rule of 300 for real quick. So what you do is you find the big boxes, and you basically find between two QRS complexes and divide the number into 300. Also, there's little 6-second markings on ECG paper. However, what I'm recommending and what you'll need to be able to do is the 300 and 150, etc., mnemonic. So you have to memorize 300, 150, 100, 75, 60, 50, 43, 38. And I'll show you how that works. So determining heart rate. So what you do is you basically find an R complex, ideally, that lines up on one of the dark lines, and then you just start counting using that mnemonic. So basically 300, 150, 100, 75, and then you can see right there that's 60. So using this, you can guesstimate that it's probably 68-ish, whatever, okay? Now, the most accurate way to do that is by far what's called the 1500 technique. So again, find an R wave that lines up right on one of the dark boxes, and then what you do is just count the number of small boxes. So 5, 10, 15, 20, that looks like about 24 boxes right there. So that's just enlarged a bit for you so you can see it. So 1500 divided by 24 equals 62.5. You always round up. The heart rate is 63 beats per minute. Now, it's important that you realize that in healthy individuals, when you inhale, breathing, your heart rate actually increases, and when you exhale, your heart rate actually decreases a little. So we get some variability in that R to R wave. So on an exam, I will always highlight where I want you to take heart rate from or determine heart rate from. So I'll either use arrows, or typically I just draw a circle around two R wave complexes, two ECG complexes. So let's look at the 300 method. You can go through, look at that. And really it boils down to about 50 beats per minute. Another one via the 300 method, and you can see there's 4 in that period, so 75 beats per minute. Now, components of the ECG. So you've got waves, P wave, you've got segments, and then you've got intervals like the PR interval or the QT interval. QT interval is very important because of something called long QT syndrome. So let's look at waves. P wave, QRS, you've got the T wave. Generally, you don't see a U wave, etc., but this is how it appears on the grid. Notice that you can see almost a straight line that goes through here. That's called the isoelectric line, and that's important because when you look at any ST segment changes, it's always relative to that isoelectric line. So P wave. You can read through this on your own, but basically it should be 0.08 to 0.10, and it represents depolarization of the SA node, which, as I mentioned, is in the top of the right atrium. So you need to know it's 0.08 to 0.10, or roughly 2.5 boxes, less than 2.5 boxes. Now, if it's long, that can suggest atrial enlargement, and if it's tall, that can mean atrial hypertrophy. So this gives you an example. You can see here right atrial enlargement. You can see how elevated it is in lead 2, and left atrial enlargement looks something different. On your exams, I won't ask you to differentiate between right or left, but just you should be able to know if the P wave looks taller than it should be or wider than it should be. So the Q wave, this is important. So the Q wave is the first negative deflection before the R wave, okay? Q waves are called significant if they're 1/4 the size or more of the R wave. So if we count this R wave, we can see it's 1, 2, 3, 4, 5, 6, 7, 8, 9. We can call it 10 millimeters. And the Q wave looks like it's just about 1. So that's not a significant Q, okay? So it's very important that you can identify significant Q waves, because they indicate that the person has previously had a myocardial infarction. So the R wave, it's the first upward or positive deflection of the QRS, and it represents the beginning of depolarization of the ventricles. If they've got ventricular hypertrophy, which is common in people with either high blood pressure, hypertension, or in athletes, it can be prolonged and it can be very high, okay? And then you also have what's called normal R wave progression, and you have to see that actually on a 12-lead ECG. So here we go. This shows normal R wave progression starting at V1 to V6. Notice, pardon me, that it peaks at about V4 to V5 and then starts to come down at V6. Notice here that we've got V1 increases, then it decreases, then it jumps up at V5 and goes down to V6. Now, here, pardon me, one second. Okay, so notice this abnormal R wave progression. So notice how it's very tall in V1 and then it decreases, goes up again, down, down. So that's a perfect example of abnormal R wave progression. Now, the PR interval. So there's, pardon me, an arrhythmia that you'll be able to identify first degree AV block, and it's just based on the PR interval. So the normal PR interval is 0.12 to 0.20, or roughly 3 to 5 boxes. If the conduction is slowed through the AV node for any number of reasons, the PR interval is lengthened. It can, however, be short in either hypokalemia, so low potassium levels, hypocalcemia, low calcium levels, or in an arrhythmia that's called WPW, which stands for Wolff-Parkinson-White syndrome. So the S wave is any downward deflection following the R wave. It represents late depolarization of the ventricles. If it's abnormally large, it also may indicate hypertrophy of the ventricles. So I'll stop now, upload this so it's a smaller upload for you, and then I'll do the second part of the lecture. Thank you.